once again as part of our series on getting a better understanding on lung cancer. This is the fourth of the series which we are doing, and I'll quickly recap the others as well. Today, we are very privileged to talk to Dr. Kumar Saurabh and Dr. Ghanashyam Biswas. Dr. Kumar Saurabh is Director and Consultant Medical Oncologist at Jharkhand Cancer Center in Ranchi, and Dr. Ghanashyam Biswas is Consultant Medical Oncologist and Executive Director at Sparsh AOI Bhubaneswar. And today we will talk about how what are the things that you need to understand about the various treatment options available for lung cancer and how you can navigate lung cancer, especially as it gets diagnosed late. So previously, we have spoken about navigating treatment options. We've talked about living well with advanced lung cancer, and we've also talked about the risk, symptoms, and treatment options. So you can find these webinar recordings on our YouTube channel, and you can always reach out to us if you have any questions. On Thursday, we will also talk specifically about managing advanced lung cancers effectively with Dr. Ankit Batra and Dr. Suhas Agre. So quick reminder, Patients Engage is an online platform for patients dealing with chronic diseases and for them and their caregivers to share personal experiences, learn from each other as well as from healthcare professionals. The important thing is that the more informed we are, the better decisions we will take, and also the more we take away the stigma around talking about these conditions, we will realize that we don't need to navigate this alone, and we have other people who are in similar situations. We've always put patients and survivors at the center of all of our conversations on any chronic condition, and you can find these conversations with our patients. The patient advocates who've spoken to us, you can find them on YouTube. You can find stories on our website. And some of them are also willing to speak with people who are currently going through the journey. This webinar series is supported by Pfizer, and the content of this discussion is for information and awareness purpose only. It does not substitute medical advice, so please consult your doctor for guidance on the information you receive, or you can reach out directly to the consultants we have on the panel. The views expressed in this video are views of the speaker, and Pfizer or Patients Engage may not endorse the same. As we said that, we are doing this for awareness. You can always contact us through our social media channels, or you can check out through our website, www.patientsengage.com. Or you can write to us at editor@patientsengage.com. And if you're live, you can post your questions on Zoom, Facebook, or YouTube, and we will try and address as many as we can. So thank you once again for joining, Dr. Biswas and Dr. Kumar. Let us start with making sure that we all understand, our audience understands what we're talking about. So if you can quickly introduce what is lung cancer, Dr. Biswas, and what are the stages of lung cancer?
So for basically any cancer is any abnormal growth which is beyond a control. So madness of any cell can give rise to a cancer. So it can start from any parts of the body from head to toe. So once we are talking about lung cancer, so we are talking about the draining areas of the lung. So the part that gets aerated and the part that covers the lung. The part that covers the lung is a pleura, so where you can get a cancer. So many times this can be a primary lung going into that, or somebody who is exposed to like asbestos or a mine, so they can get a disease, which is a bit different, but though is known as a mesothelioma. Otherwise, the bronchus or the bronchioles, which takes air into the lung system where the oxygenation gets. So these are, so the lung parenchyma, the lung coverage, and the lung that gets air from the bronchus or the bronchiole. So these, any malignant growth in this part can be said as a lung cancer or a pulmonary malignancies.
Right. So in terms of Dr. Kumar, we've talked of what is lung cancer. Can you tell us what are the types of lung cancer that patients should be aware of, and why is that important for them to understand?
Broadly speaking, lung cancer generally from a treatment perspective as well as from a classification perspective, we generally divide it into two broad subgroups. One is the small cell lung cancer, and another is the non-small cell lung cancer. The reason of this division is that basically these two groups behave a bit differently, and the treatment portion is also a bit different. Small cell lung cancer, in all probability, occurs exclusively in smokers. It is a very aggressive disease. Used to be the treatment options used to be limited till recently, and most of the cases were diagnosed in very late stages, and it was a very aggressive tumor. And the average survival post diagnosis used to be just 1.5 years at max. But slowly things have been changing on that front, and with the advent of new therapies like immunotherapies, we are making some progress in that area. The other cancer is the non-small cell lung cancer, and that forms the majority of the lung cancers which we generally deal with. And non-small cell lung cancer is also per se associated with smoking. It is again broadly classified into mainly two groups. One is the adenocarcinomas and one is the squamous cell carcinomas. And slowly we are able to do a lot of genetic testing, lot of mutation testing, and lot of new therapies have come, but in particular with this adenocarcinoma portion of the lung cancer.
Right.
So we have made rapid progress over the past few years.
Right. And what is the test that determines whether it's, the type of lung cancer?
The test which we generally do is a biopsy. So biopsy is the gold standard for diagnosing any type of cancer, and lung cancer also the biopsy is the gold standard.
Right. So, Dr. Biswas, Dr. Kumar talked of stages. If you can again elaborate a little bit on the stages and why is staging important again for understanding treatment options?
Right. So Dr. Kumar left at a biopsy. So at times you may not come at a conclusive diagnosis at a biopsy. So you might have to do an immunohistochemistry to understand. So are you dealing with a small cell versus non-small cell? And in non-small cell, adeno versus non-adenos. So now coming to stage. So as rightly Kumar said, so there are two types of disease. So 1 out of 5 will be a small cell and 4 out of 5 will be a non-small cell. So if you come to a small cell, which is almost associated with smoking, so here we don't stage as 1, 2, 3, 4. So we stage as limited stage and an extensive stage, because this is one disease. So where today surgery is not the treatment, even if you did it early. So it is basically a chemo, radiotherapy, and immunotherapy. So in a small cell, it is a limited stage or extensive. And coming to a non-small cell, then it is a stage 1, 2, 3, 4. So normally 1 and 2 are taken as early disease, 3 is taken as a locally advanced disease, and stage 4 is taken as a advanced disease. So small cell, 2 stages, so extensive and limited, and in non-small cell, it is stage 1, 2, 3, and 4.
Right. And how does this stage determine the course of treatment? Right.
So if I again come back to a limited, a small cell, if it is a limited, then we get away along only with this chemotherapy plus radiotherapy. So that's over.
Right.
If it is an extensive stage disease of small cell, then chemotherapy plus radiotherapy, and then we give a maintenance of immunotherapy. So while coming to a non-small cell, if it is a stage 1 disease, which is seen only in 10 to 15%, that's the unfortunate part of a lung cancer, that early stage diseases are not seen much, because in the COVID times, everybody has a cough. Now there is a viral flu throughout the country, so you will have a cough. So nobody investigates a cough unless and until it is for a while. So that's the reason that you don't pick up this disease early. So if it is a stage 1 disease, so usually it is a surgery. So now the advancement is that post stage 1, then you will require some amount of chemotherapy, or if there is a target, then you are going to give a targeted therapy. The same story for stage 2. So surgery followed by chemotherapy and then a targeted therapy if that is there. Normally, stage 3 is the most heterogeneous group among these 4 stages. So this stage 3, so there are some patients who can go for upfront surgery. There are few patients who can receive chemotherapy followed by surgery. Otherwise, the majority cohort in the stage 3, they will receive chemo radiotherapy and then they will receive a maintenance of a immunotherapy. Now coming to a stage 4 disease. So stage 4 disease is like a versatile actor. So stage 4 doesn't mean in lung cancer today in 2023 that is all have a dismal prognosis, because stage 4 can be a good guy, bad guy, and the worst guy can be, because there are patients of stage 4 disease, but there are molecular alterations. So this patient can go along for years together. There are patients of stage 4 disease, general condition is weak, so you don't have a molecular alteration, you don't have an options for immunotherapy, then this patient is like gone, so you don't have much options. So today's stage 4 can have chemotherapy options, they can have chemotherapy, immunotherapy options, only immunotherapy options, they can have biological options, they can have targeted therapies. So that's the versatility what is in the stage 4. Stage 3, as I said, is a heterogeneous group. So you can have options of surgery, chemotherapy, radiotherapy, immunotherapy, everything put together today in stage 3. So only early stage 1 and 2, which constitutes less than 1 out of 5 patients of lung cancer. So where surgery is the primary modality if general condition is fit, if being a smoker, the lung conditions are good enough that we can sacrifice a part of the lung or a whole lung on that side, then probably. So there is something called operability, and then there is something called, so the disease can be operated, but a patient is not fit for a surgery, right? Or the patient medical condition doesn't allow for a surgery. So that's the whole thing in regards to treatment.
Okay. Thank you, Dr. Biswas. So, Dr. Kumar, I think Dr. Biswas touched on the targeted therapy and a little bit on the molecular alteration. Can you talk through the various molecular testing and what is these days required in terms of molecular testing, and how does that determine the treatment?
Okay, so the molecular testing is actually, if you see the pie of non-small cell lung cancer, when I started first practicing medical oncology, so there were only 3 candidates. One was EGFR, one was ALK, and ROS. But slowly and slowly, the pie has been steadily expanding. We are almost every year we are detecting new mutations, and almost every year some therapy is coming to address those mutations. So the prognosis is slowly improving, especially for those patients who have a targetable mutations. Most of the Indian patients, if we talk about the targetable mutations, we generally test for the mutation through a biopsy. There are ways where we can test through blood also, which is known as liquid biopsy. But tissue biopsy is still the preferred option. And again, if you talk about testing, we have lots of tests, different type of tests to test for these molecular alterations. We can do a FISH, we can do a DNA mutational analysis, we can do an IHCs, and we can, if the patient is completely affording and if he wants to test for all mutations at one go, we can do a next generation sequencing, NGS, but that is a bit costly. So generally the type of mutation testing, ideally, if we see the mutation testing, all the patients of non-small cell lung cancer should undergo a complete panel of mutation testing. But many a times costs and other issues dictate that. So generally, if cost is an issue, generally we try for the more common mutations initially, EGFR, ALK, and ROS. So almost 25% of the Indian population, 25 to 30%, the results vary among different series, but it is close to 25, 30, 35% of Indian patients will have EGFR mutation positivity. Around 5 to 9% is the data for all positivity, and 1% is the data for ROS positivity. So these are the most commonly tested mutations in our day-to-day practice. But as I've said, the pie is completely expanding. So we have got exon 14 skipping mutations, we have got MET amplifications. So we have medicines available for against these mutations also. But the thing is, the tests are a bit costly, and the medicines also are currently a bit costly. So we generally discuss with the patients, if money is not an issue, you should ideally go for the full gamut of tests through NGS. So by NGS, we will be able to detect many more mutations for which the therapies are currently not available but are in development. So once you know that, then the patient can be given hope that maybe this therapy will be coming next year, and by that time you will be able to get advantage of this therapy. There are a few therapies which are available abroad but are not available in India. So there are ways to engage in those therapies. Dr. Biswas sir is running a lot of trials also that way. So the patient can be enrolled in a clinical trial. So there are options available. But for all practical purposes, for a patient with a limited resource, generally we do EGFR, ALK, and ROS
Right.
at the base. The rest of the mutations depending on the patient's listing.
Right. So yeah, Dr. Biswas, if you can also quickly tell us on, what is the criteria, or how do you determine whether somebody can join a clinical trial, and what is the information that you are able to share on this?
So now people should be encouraged to enter into a clinical trial. Because I've been into clinical trial for more than 2 decades now, the basic understanding, not only in the common people, even in the medical fraternity, that people think that they are guinea pigs and we are trying experiment. So gone are those days when you are giving somebody a medicine and somebody a placebo, means you are not giving anything. So today, such trials hardly exist. So now the question is that somebody is getting a standard of therapy, that is standard therapy, which is available in all guidelines. And the next is somebody is getting beyond a standard, or we are looking for a new standard. That is one thing. Second is somebody, as Dr. Kumar said, so there are drugs which are available rest of the world, so which is not available in India, or the generics are not there. So we are looking at, there are many drugs now, we are even in the immunotherapy, in the targeted therapies. So one patient will get the original drug and somebody will get a biosimilar or a generic. So it means the bottom line is that, so people are getting the minimum treatment that's acceptable. So unless and until the medical fraternity, and when they go to a family and somebody who is not an oncologist or somebody who is not a really professional, they misguide people. So clinical trial is meant for rare diseases. Clinical trials are meant for somebody who has progressed on a standard line of therapy. Somebody who cannot afford the best of therapy in the world. Somebody where the generics are available. So I think so these are situations where people should opt for a clinical trial. So because now India is among the generics, so India is probably the hub where the clinical trials are really, because there was a period sometimes so when there were limitations and because of some issues, I think now that's open, because now the people understand that unless and until you go into a structured clinical trial with a proper consenting, so unless and until you do that, you are not going to get the new drugs. So all those new drugs, even in the COVID time, so the whole initial 1 year of COVID, there were almost 18 new drugs that approved in lung cancer. So science never stopped, the research never stopped in the COVID. So that, because we say cancer doesn't go for a vacation. So everybody of us goes for a vacation. So cancer has no vacation. Disease goes on. So every individual should be encouraged. So they may be related to us or our patients or the normal population. So they should be encouraged for a clinical trial, because today's clinical trials are absolutely different. So somebody is going to get the basic treatment.
Right.
And we are looking at beyond basics. So we are looking at a new structure. So Bombay is going to get a new bridge, so which will take 20 minutes to a new Bombay. So unless and until you explore that and over the sea or under the sea, so you won't get a new thing.
Right. Right. Thank you. So coming back to the various treatment options, people are always concerned about side effects and long-term toxicities of some of these treatments. So, Dr. Kumar, if you can talk through, because people know chemotherapy and its side effects, but if you can also talk about the other treatments, including the newer treatments, and what are their uh, not just side effects, but long-term effects also.
So basically, chemotherapy, as you all said, people are scared of taking chemotherapy. But in fact, chemo also we have come a long way. Gone are those days where chemo used to be very toxic and all. In fact, I have still have patients who think that chemo is prepared from snake venom or some sort of
Yes.
bad bullshit. But I will like to rest assure the listeners that chemotherapy is a very scientific preparation. There is nothing hanky panky about it. And most of the patients who are given chemotherapy, the oncologist takes a decision whether the patient will be able to tolerate it or not. So, apart from chemotherapy, the new medicines which we have come, especially the targeted options and the immunotherapy per se, these medicines are have absolutely changed the landscape of medical oncology. So they are one I am not saying that they are devoid of any side effects. They have their side effects. They have a like in lung cancer, the most common mutation, as I said, is EGFR mutation. So first of all, most of these targeted medicine are in oral form. So oral route adds to the patient's convenience. They can simply go home and take the tablet. And if we talk about EGFR mutation,
So you've muted yourself.
we have a tablet of osimertinib.
Yeah,
So
we'll not mention any brand names or anything also.
okay.
Yeah,
So we
sorry.
have a tablet. It's okay. So no, this
Yeah.
is not random. It's a generic
Yeah,
name,
no,
but
I know it's, yeah.
okay. So we have a tablet. Now, this tablet is something which has to be taken orally. Absolutely, I have a number of patients on EGFR mutation who are taking these tablets, and it is absolutely devoid of any side effects. There is no hair loss. There is no. The only side effects is mild itching is there, and some people do get diarrhea, but nothing unmanageable. So most of these patients do have a very good quality of life, in addition to the longevity which they
Right.
get with this targeted mutations. Immunotherapies, again, immunotherapies have a special set of side effects which we call as immune related adverse events. But uh, compared to chemotherapy, these drugs are much well tolerated. And though immunotherapies do have some serious side effects like pneumonitis and colitis, but most of them are well tolerated, easily manageable. And these patients who are on these new age medicines, generally they have a very good quality of life.
Right, right. And typically, like some of these medications have cardiovascular impact, or they may, cause over a long period of time, they may cause diabetes, etc. Is that true, or is that something that can be managed? How does that, and what is
Most
the follow-up routine for that?
so we do have, matlab, if you see the list of side effects, there are a few medicines which may cause glucose intolerance. There are a few medicines like immunotherapies generally cause hypothyroidism. If you see the list of side effects, if anybody has to Google the side effect of an immunotherapy, he will get a list starting from right from head to toe. But in practical experiences, most of these side effects are either mild grade of mild severity, easily manageable. Hardly we have got any patients who we were compelled to stop the medicines because of the side effects, which generally used to occur quite more frequently with chemotherapy.
Right.
So, as compared to chemotherapies, these medicines are well tolerated, and since these medicines go on for a long period of time, people are concerned that they may lead to some endocrine or metabolic disturbances. But again, those fears are mostly unfounded. Generally, whenever a doctor prescribes these medicines, he has a knowledge of the side effects, and he keeps on testing to see every frequent and infrequent intervals, whether the patient is tolerating it or whether that side effect is developing or not. So
Right.
most of the times it is very well managed.
Right. Okay. Thank you, Dr. Kumar. Dr. Biswas, especially for, we are also seeing some of these lung cancer cases in younger people, right? So the non-small cell adenocarcinomas is affecting younger people, both men and women. What are the effects of that on fertility? And, again, what is the guidance that you give to the younger patients?
Yes, absolutely right. So there is an increased incidence of lung cancer, especially adenocarcinoma in young male, female, and as a whole, the woman population as a whole. So the cancer incidence, which is supposed to be a male dominant disease, so now it is more common. And surprisingly, this most of these females, like country like us, so where they are non-smokers. When these young people who are in their 30s, we get a lung cancer, which was never thought of years back, especially.
Correct.
So these are, so now we are thinking that smoking is not only a factor that causes lung cancer. So there are factors beyond the smoking. So these can be a environmental factors. So there can be a genetic factors. So which probably is driving. So today you see a 70-year female who's a non-smoker. So either you look at the patient's husband or a son who's a smoker, or the patient used to use a chula in their home. So that can be a cause. Or somebody who stays in a steel industry or steel factories nearby. And I belong to a SAIL, so Steel Authority of India Limited, Rourkela, where used to be huge population. So in Odisha, there are areas like Onugul. So we see lots of plants coming up. So pollution control is still there. So there are individuals who works in the mines. There are patients who individuals who works in the asbestos factories. So that's their livelihood. There are individuals in the hospitals who works in the radiation unit, radiology unit. So they have a lead apron. So these are varying reasons that, and there are genetic factors. So 1 out of 4 or 1 out of 5 in lung cancer are genetic, not the genetic alterations that happens after the lung cancer. There are genetic alterations that are happening that are giving rise to a lung cancer. So like we talk about BRCA family, or getting a
breast cancer, right?
Ovarian cancer, or a pancreatic cancer, or prostate cancer. So even 1% of BRCA family have lung cancer, right? So there are P53 mutations or the leaf remini. So where you can get n number of cancers, so hepatocyte cancer. Some member is getting a breast cancer, some member will get a stomach cancer, somebody will get lung cancer. So these genetic inheritance or a penetrance, so the understanding which may not be a horizontal or vertical, so this can be epigenetic. So that's the reason that we are, and this is an unfortunate part that this incidence is increasing. The fortunate part is that this subset of patients, these young patients or these females who are non-smoker getting adenocarcinoma, so such type of molecular alterations, what Dr. Kumar was saying, so you pick up more. So these are patients where you can go up to 40%. There are paper series, 45%. If you look at the rare mutations, so it can go up to 50%. So you can get a genetic alteration. So they may not require chemotherapy, they may not require immunotherapy. So they can get away with some of the oral pills.
So those don't have effect on fertility, etc. These oral pills or targeted therapies.
So when you talk about fertility in cancer, so oncology and fertility itself is a chapter. So we normally talk about this in a curative setting. Somebody is getting a testicular tumor at the young age. Somebody is getting an ovarian cancer at a young age. Somebody is getting a leukemia, lymphoma. So these are tumors where, so probably there are drugs like bleomycin and XYZ. There are many drugs, etoposide. So these can cause some fertility issues in males and females. So these are cancers. They are a curative intent. So 8 or 9 out of 10 cancer patients of these diseases can get cured. So here in their reproductive age group, if they don't have, either they are not married or they are married, they don't have issues. So you try to preserve the spermatozoa or the oocytes. But in lung cancer, so the basic dictum is that unless and until it is an early stage, we don't talk about cure today. So that's why, so the fertility issues are actually not documented, or we don't talk much about fertility. So these fertility issues comes when happens in a younger patient population, and then with a curative intent, because in a short term, 6 months, 1 year, 2 years, we don't talk. Otherwise, every drug can cause, as Dr. Kumar said, so it can have toxicity from head to toe, but so from 1% to 20%. So this can, because if it is more than 5%, it is documented in any of this literature. So that's why in lung cancer, normally, or most of these, when they are advanced disease, we don't talk about fertility much.
Right. Okay. So I think we are pretty much on our 30-minute mark. Just final questions to both of you. Dr. Kumar, if you can, what is the message that you want to give, especially from an emotional standpoint, to lung cancer patients, or people who are just being diagnosed, or they're struggling with the condition?
So the first and foremost is not to lose hope. As I have said, we have taken huge strides in medical oncology per se over the past 20 years. And cancer per se is, for all practical purposes, is not the end point. It's not a death sentence, which most of the people still believe it is. So you have to be positive. And I keep on giving examples of my patients. When I joined Ranchi in 2013, one of my patient with stage 4 lung cancer with brain metastasis is still alive. And so there are success stories, though far and few between. But most of the patients, generally with this new age therapies, they tend to lead a good, active, and happy life. So many a times the patient of lung cancer generally have a nihilistic predisposition. So once you tell that, okay, it's an advanced disease, it won't get cured, so patient generally start thinking about they become sad, they become depressed. So to counter that, let's say you talk about any chronic disease, hypertension never gets cured, diabetes never gets cured. So finally, the point of modern era medicine is to make cancer like a chronic disease, like diabetes or hypertension. You can keep on taking medicine and you keep on living your life, healthy life, with very few restrictions. So that is the general concept which all over the world we are thinking that cancer may become in near future. So for that, the patients also need to have a very positive mindset. So it is not an end sentence. We can give you a very fruitful and long life, even with advanced stages of lung cancer.
Right. Thank you, Dr. Kumar. Your final message, Dr. Biswas?
So now I'll just narrate three points. Number one is stay away from addiction. So be it a tobacco in any form. So God, now in a modern era, we have enough of problems of pollutions. Now you go to northern part of the country, there is a problem of smog, there is a problem of fog, right? So unless we understand that, we stay, because 40% if tobacco wouldn't have been there, then 40% cancer burden would have come down. Second is that, so this can be a statement for our own colleagues who are who are the first point of contact for any patient in their sufferings. So all X-ray shadows are not tuberculosis or pneumonia. So you can have a cancer. We discussed, so it can be a young non-smoker, it can be a young person. So you don't treat a X-ray shadow thinking or empirically with anti-tubercular for continuing together. So if you have suspect, so try to evaluate. So in 2023, so everything is possible, and there are government schemes are available. So money is not a problem today, because for basic treatment, so government, every state, like my state government, so for a male 5 lakhs and for females 10 lakhs is free. So don't indefinitely treat as X-ray shadow. So don't at times you might over investigate. So there is no foul playing in doing an over. So if you are in doubt, do a CT scan. If there is a node, You try to do an FNAC, if this is not conclusive, do your biopsy. So you might miss out a lung cancer, because if you are delaying a treatment, so there is a long-term effect, so on a survival is there. So it has been through series of papers for last 3 decades. So in India, the problem is that tuberculosis, because you don't see much of tuberculosis beyond Asia. So you don't treat like our MBBS guys, or like as an oncologist, if I see an X-ray, to me it looks like a malignancy. So somebody is an X-ray who looks a physician or a pulmonologist, so for them it looks like a tuberculosis or a pneumonia. So that should not be. And the third thing, as Dr. Kumar rightly said, so today, so don't get depressed. So because, so positive frame of mind, so be it a diabetic cancer, so because a stage 4 cancer with the same disease, same type, don't behave the same. So like the 5 fingers, because so there is something called positive. So if you have a positive frame of mind, if you take this in a stride, so definitely you are going to be a different. So be a different, and once you have overcome that, so be a part of a support group, which is not very prevalent in our country, which is seen in means rest of the world, like US or the Europe. You see, for every cancer, so to November is a month for a lung cancer, and the good part that we are discussing about lung cancer, and a good part again is that lung cancer, which used to be the class number 1, because so used to come first in the class, so now it has become second. Unfortunately, breast cancer in females has become the number 1 cancer in 2020. Again, so there are various reasons. So lung cancer is standing second in terms of incidence wise, but still mortality wise, death wise, lung cancer is still the number 1. So with statutory thing, that probably we can still come down much down in the ladder in regards to the incidence of lung cancer today.
Thank you. Thank you, Dr. Biswas and Dr. Kumar, both of you, for taking the time to answer, as both of you have very strongly said that, lung cancer, even 4th stage, is not a death sentence. So do not stay positive and understand the treatment options and go through the necessary diagnosis to get to the right treatment. And as again, both of them have said, it is important to understand that there are treatment options and that people are living for many years. And I think as I think this is one of the big challenges that we continue to see is be vigilant about your chronic cough. So don't ignore it. Don't self-treat it. Don't just think it's pollution. Do get it checked out as well, so that you do pick up any eventualities like lung cancer early. And, people often think cancer doesn't happen to me, and they kind of keep, delaying these investigations. So don't do that. I think it's important. The earlier we diagnose lung cancer, the better the outcomes. So thank you once again, Dr. Ghanashyam Biswas and Dr. Kumar Saurabh, for your time. And thank you, Pfizer, for supporting this session.
Thank you so much. Thank you.